Okay, let's get started, everyone. Hi, everyone. My name is Marie Malloy, and I'm your moderator for today's webinar. Before we get started, I just want to go over a few quick things. Today's presentation is being recorded, and it will be available in FAIR's Food Allergy Academy in about a week to 10 days. To maintain a quality recording, attendees are muted throughout this webinar, but if you have questions, please use the Q&A feature on Zoom to ask questions. They will be answered there by a FAIR staff person or at the end of the webinar. At the close of the webinar, there'll be a link to a survey. Please let us know how we did. And if you are seeking continuing education credit from the Academy of Nutrition and Dietetics, you must fill this out. Certificates will be sent in about a week. Now, without further ado, it's my pleasure to introduce today's presenter, Dr. John James. Dr. James has worked in the field of allergy, asthma, and immunology for more than 30 years. He's a board certified by the American Board of Allergy and Immunology and has clinical experience in the diagnosis and management of allergic diseases and asthma with a special interest in food allergy and anaphylaxis. Dr. James was a medical school faculty member at the University of Arkansas in Little Rock and worked with Colorado Allergy and Asthma Center for 24 years before retiring in 2020. I will turn it over to you now, Dr. James.
Okay, Marie, I was trying to advance the slide. It didn't seem to be advancing on my end, but I can. If you want to advance to the first slide.
So I am afraid that I cannot on my end because it's opened on your end.
Okay. Let's see here. Okay, there it goes, but I'm going to see if I can now. Okay, good.
All right.
Thank you so much, Marie, for that introduction. I also want to thank the other FAIR staff members here, Anita Roach and Tiffany Leon. Really appreciate all the help they have given me with this series. This is the 4th of 5. It's really flown by this year, and we have one more scheduled in November. These are my disclosures. And the objectives are listed here. We're going to do a quick review of the management of anaphylaxis. Since this webinar is focused on treatment, I'm going to talk about appropriate food elimination, avoidance diets, focus on specific nutritional issues with elimination diets, immunotherapy for food allergy, which is an exciting area of food allergy over the last many years, and biologics used for food allergy. This is a rapidly expanding area as well. So going back to some definitions, food allergy is an adverse health effect rising from a specific immune response. That's key, and occurs reproducibly on exposure to a given food. Example would be IgE-mediated reactions to peanuts, cow milk, egg, and tree nuts, some of the common food allergens. Allergic reactions can cause symptoms in the skin, mouth, eyes, GI tract, lungs, heart, and brain. Mild and severe symptoms can lead to serious systemic allergic reactions called anaphylaxis, which can be life-threatening. On the other hand, there's food intolerance, which is a non-immune reaction. It's an adverse physiologic reaction following food ingestion that can include metabolic, toxic, pharmacologic, and undefined mechanisms. The most common example that you're familiar with is lactose intolerance. So this, again, is a review. Anaphylaxis, we talked about the last webinar, is a severe allergic reaction that can be life-threatening, caused by a group of symptoms involving multiple systems in the body, mainly the skin, gut, lungs, and cardiovascular systems. The symptoms may occur shortly after having contact with an allergen and worsen rapidly. Usually this occurs within the first 30 minutes up to 2 hours. These can be reversed if appropriate medication is given. Epinephrine is the gold standard for treatment of anaphylaxis. And we'll go through some emergency management issues on the next couple of slides. Patients require immediate assessment and treatment if they have anaphylaxis. Start with removal of or the exposure to the known allergen, suspected trigger, followed by assessment of the patient in terms of their circulation, their airway, and breathing and mental status. Administration of epinephrine is critical. And this, I can't stress this enough, because this is the treatment for anaphylaxis, the gold standard treatment for other therapies are given. There's no absolute contraindication to use epinephrine. It's safe and it's without major side effects. Evidence has shown that delayed administration of epinephrine is associated with increased rate of hospitalization and even mortality in some cases. So after the administration of epinephrine, the patient should be placed in the supine position on the back with their lower limbs, their legs elevated to increase blood flow back to the heart. But if a patient can't be in that position, they can be moved to the upright position if they're having trouble breathing or having vomiting. Continuous monitoring of vital signs is recommended. Supplemental oxygen if needed, and an IV placed for fluids. And again, epinephrine should be given early, and it can be repeated 5 to 15 minutes if needed. It's important that follow-up monitoring in an appropriately equipped healthcare facility should be followed. That way, patients can be monitored if they have respiratory compromise for 6 to 8 hours in an emergency room. And then if there's hypotension or cardiovascular problems, the patient needs to be monitored for up to 1 full day. So they're admitted to the hospital generally. On discharge, need to discuss appropriate allergen avoidance. We'll be focusing on foods here, but in other anaphylaxis cases, following medications like penicillin or bee stings, the same thing would apply. So a prescription for epinephrine auto-injector is usually a 2-pack, and advice on how to use it. So there has to be a demonstration with the trainer. Some people get the epinephrine auto-injectors and they're not shown how to use them. Follow up with an allergy specialist for further workup and management. And then a written emergency care plan is critical. This identifies the patient's information, their age, their birth date, their weight, who are the contacts for that patient, how to recognize symptoms, early symptoms like skin, intestinal symptoms, respiratory symptoms, and how to manage reactions, and then a list of contacts, who to be identified, parents, caregivers. This is just an example of FAIR's emergency care plan. You've seen this, it's online, it's available. Your healthcare provider should have access to this, and these can be used for educating the patient about how to follow a treatment plan. It includes prescription of how to use an epinephrine auto-injector, the steps to take during an allergic reaction, and this can be used for the patient to have, for their caregivers, and for schools, and when travel is undertaken. This is just a scenario of a patient that I had when I was in my fellowship in Baltimore. So a 40-year-old man who has been in general good health until 6 months ago when he developed vomiting, generalized diffuse hives, and difficulty swallowing. He was having trouble with his throat 20 minutes after ingesting crab cakes. And he had eaten shellfish in the past for many years, shrimp, crab, lobster, et cetera. And this was a new thing for him. And he has not eaten any shellfish since his reaction 6 months ago, but he's here for an allergy consultation. And what's the likely diagnosis and what should be recommended? So the diagnosis of anaphylaxis shellfish is most likely from this history due to the clinical symptoms and multiple organ system involvement. Allergy testing can be performed. We usually have to wait many weeks before we do the testing because the skin test could be negative because the patient just had anaphylaxis and released mediators that would be seen in testing. So we can test for crustacea here. It'd be shrimp, crab, lobster. We could also do mollusks, which are clams, oysters, and scallops. And then this guy had a positive skin test to crab and lobster. We give appropriate food allergen elimination information. An emergency care plan can be filled out as we discussed, and prescriptions for epinephrine auto-injectors. Usually I would prescribe a couple, and these would be 2 per pack, so they end up having 4 total auto-injectors. And follow up in 6 to 12 months. Skin testing may or may not be necessary. Now we'll shift over to really some of the bulk of what we're going to talk about today, and that's nutritional intervention. We need to ensure avoidance or restriction of the relevant food allergens. So we need to hone down on which foods to eliminate and which foods not to eliminate. We don't want to keep restricting foods unnecessarily, but we want to focus on which foods are most appropriate to eliminate to prevent allergic reactions. We ensure adequate nutrition in the context of that food allergen restriction, and recommend appropriate dietary alternatives. So if there's a cow milk allergy, we can a lot of times use soy milk or other things that will be appropriate. And then we want to prevent malnutrition and inadequate growth. This is critical because if patients keep eliminating, say they have a bunch of testing, then we'll talk about this later, and parents just keep restricting foods based on skin testing only or testing that's not appropriate, then you could lead to a lot of inappropriate elimination. And then the last point, referring to a registered dietitian who has experience in food allergy can be extremely helpful and critical in the overall management plan. So appropriate dietary elimination outlined here. Complete avoidance of, let's say, for peanut. We want to avoid peanut and foods that contain peanut and foods that could cross-react with peanut. Sometimes that's tree nuts. Partial avoidance, this would be like in patients who have egg and cow milk allergy, unbaked, but they can tolerate baked egg and cow milk products. I'm going to talk about this in the slides after this one. The FALCA came out many years ago, and this is the Food Allergy Labeling and Consumer Protection Act of 2004, labeled the 8 major food allergens that needed to be labeled on food products. And this was a critical step. We saw a major milestone really for food allergy in patients and parents that are reading labels and need to know what to avoid, when to identify food allergens. Recently in 2021, the FASTER Act was approved by Congress and signed into law, and this added sesame to the major food allergens. So this is going to go into effect in 2023. So food manufacturers need to label sesame in addition to cow milk, egg, peanut, soy, wheat, tree nuts, fish that are listed on labels to identify so people can know when these foods are in products to avoid them. There are also advisory warning labels that manufacturers they're not required to list, but they may say may contain milk, may contain egg, may be in a facility that's processed in a facility that have peanuts or tree nuts. So these are helpful, but they're not the gold standard here, unfortunately, and we have to be careful, and they're not always labeled. So parents ask about this frequently. So we have to be, if a patient has peanut allergy, I will tell the parents to be aware of this and to be very careful if these are on the label. Then there's cross-contact issues, shared equipment, fried foods, say French fries that are fried in something that had shrimp previously. We have to be aware of these things. Breastfeeding, in terms of food allergens, exclusive breastfeeding is recommended for the first 4 to 6 months of life. This is for all infants. So up to, and sometimes up to 1 to 2 years. If breastfeeding can't be done, an iron fortified formula, appropriate formula should be given. And then I also threw in here, this is going to be what we talked about the last webinar, but I put this in here, introduction of adequate and safe complementary foods 4 to 6 months when the infant can tolerate these foods, obviously, and then continuing breastfeeding up to 12 months or sometimes up to 2 years, and focusing on diet diversity. So we want to add different types of foods because this can help prevent food allergy. And then I'm sure you're familiar, hear about this all the time in the press and scientific journals that introducing allergenic foods, mainly peanut, but also egg, cow milk, can, when appropriate, can have a beneficial effect in preventing food allergy. If you continue to wait to introduce these foods, there may be an increase in allergic reactions to those foods. So if you wait after a year or up to 2 years, well, that could be problematic. And then the maternal exclusion of relevant food allergens if that infant has a milk allergy to like egg or milk. I get this question sometimes from mothers and I tell them they should exclude that food allergen if the infant has a known food allergy. So this is a scenario: a parent of a 2-month-old female asked about preventative measures for allergy, including food allergy in their infant. The family history is positive for asthma and allergic rhinitis, so atopy is in the history. The mother and the eczema and the dad. There's a 3-year-old male sibling with uncomplicated egg allergy, but otherwise no medical problems. And what are the best recommendations to provide at this point? So exclusive breastfeeding for at least the first 4 to 6 months. Feed a iron fortified formula if breastfeeding is not possible or can't be continued. Introduction of safe complementary foods, solid foods, when it's appropriate, when the infant can tolerate those, together with breastfeeding or the formula. This could be grains, fruits, legumes such as beans, and introducing allergenic foods like peanut and egg. These are the 2 big ones. And then cow milk, tree nut, wheat, shellfish, when appropriate, in those early months of like 4 to 6 months and beyond. This is a big shift from what I used to recommend when I was in my training many years ago, when I was in early practice. This has been an evolution in my career as an allergist, and I'm sure many of you are familiar with these new recommendations. So what about what you know about hypoallergenic formulas for cow milk allergy? Well, starting with soy-based formulas, if you have an infant that has cow milk allergy and they're not allergic to soy, well, soy could be a good alternative for that infant. They're cheaper, they taste good, and they could be substituted for cow milk because the infant with cow milk allergy can't have cow milk or formulas that have cow milk protein. Partial hydrolysates are like Good Start, Peptamen, Pediasure. These are not recommended because they do have proteins that are not broken down to a small enough protein that would be tolerated by that infant. But the extensively hydrolyzed formulas like Alimentum, Nutramigen, Progestamil, they're tolerated up to 90% in cow milk, in IG-mediated cow milk allergy infants. This can be a good alternative. They're more expensive, but these can be very useful for parents to use in their infants with cow milk allergy. And then there's the elemental amino-based formulas that came out probably 25 years or so ago. And these are Neocate, Elecare, Pure Amino. These are, the proteins are broken down to the basic building blocks, the amino acids, and then the other nutrients are added. So these can be fed to cow milk allergic infants with food protein-induced enterocolitis syndrome, and patients that are intolerant of the extensively hydrolyzed formulas, even in eosinophilic esophagitis infants. So very beneficial formulas. They are expensive, but they are there to use. And you've probably heard that this past spring up into the summer, with the outbreak of COVID-19, there were shortages of some infant formulas due to supply chain issues and some recalls. This has been rectified, and we're seeing more and more getting back to where we were in terms of the supply of these formulas, which is great. So going back to elimination diets, we want to strictly eliminate the relevant food allergen recommended for that patient. If they're peanut allergic, egg allergic, milk allergic, etc., and focusing down on what needs to be eliminated without eliminating other important foods. Standard of care to manage or prevent food allergy. We need to provide appropriate education for the parents on reading labels, recognizing hidden ingredients, appropriate reading of labels. So this is where the FASTER Act is really is continuing to help our patients and their parents identify what foods to avoid. Clinician experience is needed to tailor. So not all clinicians are educated on this. So healthcare providers need to be aware. We as allergy specialists need to educate our pediatricians, our family practice doctors, nurse practitioners, our physician assistants to be aware of these things and to provide education, because most patients are coming into the healthcare system through their primary care providers, and then they would appropriately refer to an allergy specialist when needed. And again, the consideration of a registered dietitian, I can't stress this enough, can be very useful in our management going forward. So elimination diets, there can be thresholds for clinical reactivity. This can vary dramatically among allergic infants and children and teenagers and adults. So there's some that are super sensitive. They may react to less than a milligram of peanut protein or egg protein, whereas other patients, they may have higher thresholds and they can tolerate, they may not react until they get a much higher amount of protein. The issue with baked versus non-baked has become more and more relevant and prevalent with research studies over the past several years, and the next slide, I'll go into that in more detail. So clinical studies have shown that individuals with egg or milk allergy can tolerate baked forms of these foods in low amounts and not have reactions, and this may be beneficial to them long term. There's also the issue of highly refined or processed foods like soy lecithin in the label, which I generally don't avoid if it's just soy lecithin and no other soy product. Then highly processed oils like peanut oil, tree nut oil, sesame oil, seed oils, not the cold pressed or like gourmet oils. I'm talking about commercially available, highly processed oils. You probably are familiar with this. So food allergy and baked foods in more detail. These baked foods like cakes, muffins need to be cooked at 30 minutes at 350 to 400 degrees Fahrenheit to be really baked. And these can be used and tolerated in some children with cow milk and egg allergies. These patients typically do have allergic reactions with non-baked forms of these foods. And if these foods are sufficiently baked and regularly consumed, they may help accelerate the process of tolerance to these foods, which can be great for the parents of these infants and children. Gives them some hope that, hey, this could help tolerance development. So that maybe their infants and children may be on a faster track to outgrow the food allergy. And this is becoming more accepted. And there have been great studies in the medical literature on this very issue. So elimination diets, food allergy. Some foods are easier to avoid than others. It depends on social and cultural factors. The diets must be carefully monitored over time to prevent nutritional deficiencies and decrease quality of life. Again, the registered dietitian can be helpful here. And it's good to have dietitians that have a familiarity with food allergy. Make sure there's other nutritional things are in place, proteins, vitamins, minerals, and then periodic assessments like weight, BMI, et cetera. These things need to be followed clinically. So if you have dietary limitations, especially with multiple foods, then malnutrition could occur. It can lead to deficiencies of micronutrients, vitamins, minerals, trace elements, and children could be at risk for inadequate growth. So I think the healthcare provider needs to be familiar with these things and be comfortable with this. And if not, get the dietitians involved and have a team approach for the family and the patient. So we got to be careful about protein deficiency. We look for weight and growth and have appropriate replacement. So we talked about earlier about replacement of cow milk with extensively hydrolyzed formulas or amino acid-based formulas. And in children, use of animal or vegetable milk sources such as and soy-based formulas. Monitoring for calcium and vitamin D deficiencies, among others. So what about food allergies and use of vaccines? Sometimes food allergens are present in medications and vaccines. We get a lot of calls about this, not only in vaccines, but in certain asthma medications, inhalers, and things like this. So patients with egg allergy can receive vaccines with little to no egg protein. This has been known for quite a while, and studies have been done to show this is safe with influenza vaccines, with MMR vaccines, but we still get lots of questions about this from primary care providers. On the other hand, rabies and yellow fever vaccines are not used that much in the United States, do contain significant amounts of egg protein and should not be administered to egg allergic patients. The yellow fever vaccines would come up, in my experience, with military. People in the military who are traveling to different parts of the world, this issue might come up. Now, gelatin in vaccines was also an issue many years ago. Gelatin in and of itself, it's a protein found in collagen. It can be a problem for patients with a history of an allergy to this protein, and gelatin can be in some vaccines like the MMR, measles, mumps, rubella, or in varicella vaccine or the chickenpox vaccine. So these things need to be on the radar screen and be paid attention to. Healthcare providers need to be aware of this. So a 5-year-old boy is behind on immunizations for school entry. He does have a history of atopic dermatitis, asthma, and allergies to egg and peanuts. So very allergic or very atopic. He's lacking these vaccines: measles, mumps, and rubella, diphtheria, tetanus, acellular pertussis, and oral polio. I can speak to this over the last 3 years because of the COVID pandemic. We've had patients who didn't get vaccine, were behind on vaccines, and now we're trying to catch them up. So this could come up. The family wants him to catch up and on vaccines on these and get the influenza vaccine. So what should be done about the vaccines and the history of egg allergy? Well, we talked about on the previous slide, the patient can receive the MMR vaccine, the diphtheria, pertussis, tetanus and pertussis, and the flu vaccine and polio. So we need to be aware of the catch-up routines and guide the family, make shared decision making with the family to say, we need to catch up. These are the things we don't need to be worried about. These are the things we need to be worried about, and educate them and move forward. So I alluded to this earlier. Unsubstantiated or unproven diagnostic food allergy testing can lead to inappropriate dietary restrictions. I've certainly seen many patients who just their foods get eliminated just based on inappropriate testing, or even regular skin testing without a clinical history. Just foods continue to be eliminated. They stack up, and you see these infants and children who are on multiple food restrictions without proven food allergies. So these are some of the unproven, non-validated tests, mainly the IgG4 testing and cytotoxic testing. And so that we see this in clinic, we try to educate families, try to get the foods back in that need to be back in, and eliminate the foods that need to be eliminated. So if you eliminate, just continue to eliminate, there could be possible nutritional deficiencies. I'm going to spend a little time on some of the scenarios that have happened. Like what do parents do with their children or themselves that have food allergies in restaurant and travel? This is becoming a big issue now with treatment of patients on the airlines. You've probably seen a lot of this recently. So you need to declare your food allergies to restaurant staff. I was recently flying back to see my family, and on every plane I was on, there was an announcement, which wasn't true many years ago. The staff, the flight attendants made really clear statements and announcements about there were patients on that flight with peanut or tree nut or whatever allergy. So when traveling, avoid eating airline food, bring your own food, inspect seating for residual food, clean the seats and tables before the patient comes in and sits down. Some airlines provide additional accommodations if you request them, and have your epinephrine, your treatment plan, your other medications with you. Don't pack them away. This is extremely important because that plane may not have everything you need. They might have epinephrine, but it's not easily accessible. They might not have epinephrine. So these are important issues. Dining out, choose restaurants that follow best practice. Well, you can call ahead and try to do your best to be prepared. High-risk places would be bakeries, Asian restaurants. Research the menus, inform the wait staff, talk to the chef if possible, have your chef card. Spare has these available online. Ask about ingredients. Talk to the chef. The chef will come out maybe and talk to you. It's rare that you have restaurants that are going to say, "Oh, we don't do any of that. We're not going to help you there." That's crazy if they do that, because they're just going to lose customers anyway. But you need to be proactive. They need to be responsive. If the restaurant does a good job, you can always write a great review, and other families can see that. So key points here. Dietary elimination, we spent time on that. Consult with a dietitian if you have access to that and it's necessary. Know about potential risk factors. I didn't speak to this earlier in this talk, but I talked about this in other webinars. High risk factors can be asthma. If the patient has asthma, they can be higher risk. If they have other allergies that could complicate things, and if there's a delayed epinephrine use, we did speak to that. Epinephrine's first line treatment, the gold standard, and there's no absolute contraindications. Following these measures, patients should be educating on avoiding their allergens. And there's many ways to do this with their provider, with online resources like FAIR and other foundations that deal with food allergies, how to recognize signs and symptoms early, how to deal with allergies at school, social events, and travel. Again, being proactive with school administrators, with the school teachers, social events that can occur at school to try to eliminate exposures. We talked about travel, when to use epinephrine, how to use it. These are basic things. How, with the trainer device, go through the steps of how to use that device so people are more comfortable when they have to use it. And a written emergency care plan. Can't stress that enough. So now we're going to talk about some other therapies for food allergy besides restriction and early prevention measures. We'll talk about oral immunotherapy the most, then sublingual immunotherapy, epicutaneous immunotherapy. We're going to talk about biologics, anti-IgE, or that's Xolair or Omalizumab and others, and then anti-IL-4, IL-13. Some of you are familiar with Dupilumab or Dupixent. We'll talk about that. So oral immunotherapy has gained a lot of press and interest in the food allergy community and other communities. People want to know about it. We're seeing a lot more research being done and information disseminated. So it can lead to successful desensitization. It does not cure food allergy. It can lead to desensitization, which could allow a patient's threshold to be increased. And if they have an accidental ingestion, maybe they wouldn't have a reaction like bite, what's called bite protection in some situations. Several foods have been studied, especially peanut, cow milk, and egg, but certainly other tree nuts, wheat. Begin with a subthreshold dose, meaning that the dose is smaller than the patient has reacted to on a challenge or in a clinical situation. And you can use a variety of things, powder, peanut flour, mixed with another food or a juice that's tolerated. There are both FDA approved and non-FDA approved protocols being used. So oral immunotherapy, there's an initial buildup phase with increasing doses of the food allergen given in escalating doses in a clinic setting that's appropriately staffed and equipped to treat anaphylactic reactions. That is important. And then there's home administration doses once they reach their maintenance dose and then they come back in every 2 weeks to be increased or have dose escalation. So after maintenance is achieved, patients regularly come back in hopes of slowly inducing desensitization. I'll mention Palforzia, which is the first FDA-approved peanut product for oral immunotherapy. And then there's also commercially prepared forms of food allergens like peanut flour, cow milk, egg, and tree nuts. I'm sure most of you on this call are familiar because more and more allergists around the country are doing oral immunotherapy in their clinics with appropriate observation and management. And this has really become a huge thing of the last 5 to 6 years or so. I'm going to focus on Palforzia because the protocols are FDA approved, but this could be true for some of the non-FDA protocols that are established with your provider in the clinic based on what's being done around the country. So the dose and administration for oral administration, you don't swallow the capsules, they come in capsules. You don't inhale the powder. The capsules are opened, or the sachets, and they are emptied into the food that's appropriate to use for the challenge, mixed well, and then consumed in entire volume or the food product. Patient is observed for 60 minutes after the final dose. And on the left side, you see the typical pattern, the total dose or the dosing administration, the buildup, and the configuration of the dose. So it starts at, say, 0.5 milligram and then goes up to 6 milligrams. This is just to give you an idea in the clinic what is done, actually done it during that day. So that first day can be a long visit. Each dose separated by about 30 minutes. The total time could be 4 hours. So think about this in the clinic. It's going to be a long half day or day in that first visit. Not all patients get up to the final dose of for that first day of 6 milligrams, but so they have to be adjusted. But the goal is to get to 6 milligrams, and then this shows you the typical updosing after that first what's called IED, which is the initial escalation day, and then the dose escalations are shown on this slide. The goal is to get to 300 milligrams, which is a little more than a peanut. That's what the goal is to get for maintenance therapy going forward once they're at their final dose. Not everybody gets there, but the goal is to get there. So there are more allergic side effects with oral immunotherapy than other forms of immunotherapy I'll speak to after this. And these can include even anaphylaxis. That's why these have to be done in the clinic with a trained healthcare provider or allergist to be there for observation. Adverse gastrointestinal reactions occur in about 20% of patients, and mainly eosinophilic esophagitis. 5% of patients undergoing OIT. Dosage adjustments are frequently required because of viral illnesses, exercise, menses, to keep it safe. And seasonal allergies can also impact the oral immunotherapy. Patients using this form of oral immunotherapy will be expected to strictly avoid the relevant food allergen and carry an epinephrine autoinjector. Again, this is not a cure for their allergy. So a 15-year-old girl has been on peanut oral immunotherapy for the past year. She's been tolerating the 300 milligram daily dose. She recently experienced an anaphylactic reaction during a soccer match. Symptoms include hives, upset stomach, a cough, difficulty catching her breath. She has a history of seasonal allergies, but no history of asthma. Of note, she did take her peanut oral immunotherapy dose 1 hour prior to playing soccer. So this is a case of cofactors impacting someone that's on oral immunotherapy. So she had her dose, and she went to a soccer match. It was very active during the match, and she had a reaction because it was within that time frame. Other factors that can contribute would be a viral infection, environmental allergies like seasonal allergies, exercising within 2 hours like this teenager, and then menses or altered gut absorption. So with these things, there needs to be adjustments to their dose, or make sure they ask about this in the clinic. If someone just had a soccer match and they're coming in for their dose, we need to be aware of that and adjust the protocol accordingly. Development of oral tolerance determined by oral food challenges can be seen on active versus placebo, and this was shown in Palforzia studies. If reaction occurred, they were less frequent on the active treated versus the patients who were not treated. Therefore, oral immunotherapy can reduce the likelihood of an allergic reaction after peanut ingestion, and if they occur, the severity can be less. So this could be what you may have heard like bite protection, gives that patient that, gives them some assurance that this is going to work, and why would they undergo it if it's not going to give them some benefit? It can also improve their quality of life. So recent studies have shown that low-dose peanut oral immunotherapy and peanut epi, which is epicutaneous, I'll talk about this, can show meaningful oral quality of life improvements. So lastly, with oral immunotherapy, the questions remaining are, do risk of adverse reactions outweigh the risk of accidental exposures? Desensitization versus tolerance. Well, we know it's going to help with desensitization, but complete tolerance is still an unknown. This is certainly hopeful in the future with treatment. Standardization of extracts, protocols, and duration of treatment. This is why it's important to talk to your allergist who's doing this in their clinic and make sure they explain what the extracts are, explain what the protocol is, and what the duration of treatment. What are the side effects? You don't want to jump into this therapy without knowing all these things, and allergists are going to be very willing to go over this before you start. So you have maybe a visit set up just to go over the risk and benefits of therapy before you do that initial dose escalation. That's pretty standard. Sublingual immunotherapy. It's been evaluated with peanut and a few other foods. It involves application of the allergen extract under the tongue, held for 2 to 3 minutes, and then swallowed or spit out. This is done daily after they get to the dose. It's well tolerated, minimal side effects. Main side effect is mild, transient, or short-lived oral itching with tingling in the mouth. Systemic reactions are rare and generally mild. Slit has been shown to offset modest desensitization, less than oral, and most patients are at least partially desensitized. Persistent tolerance after discontinuation of therapy is uncommon. Epicutaneous, this is an area that's really exciting. This is doing a patch on the skin. It's been evaluated for the treatment of peanut and cow milk allergy, involves application of a small allergen patch to the skin of the back or upper arm with patches changed at 24-hour intervals. It may be years of therapy, but it's a little easy to administer, not orally. It's on the skin, low dose allergen exposure, and it can induce moderate desensitization, but it's not effective right now as effective as oral or sublingual immunotherapy. Very excellent safety profile. Typically, mild irritation is noted at the patch site, but not other adverse effects we discussed with oral immunotherapy or sublingual. It may be efficacious if initiated in younger children. The precise role of EPIT in the management of food allergy has yet to be determined. It's under the review by FDA. And this is getting very close. At a meeting I went to in July, the studies are getting closer and closer and reviewed by the FDA for approval. And this, you'll hear about this, and you'll hopefully this will become available. So future therapies, we'll talk about biologics, but oral immunotherapy in combination with biologics like Xolair, anti-IgE, and Dupixent, or anti-IL-4, IL-13. Sublingual immunotherapy, more will be revealed here. And then I just mentioned the epicutaneous patch immunotherapy. And we talked about baked egg and milk as a form of treatment. So Xolair, or anti-IgE biologic therapy. This is in conjunction with oral immunotherapy. So it can be used for a variety of foods, medications. This is the medication that targets the IgE antibody. And just like it's used in asthma, it was developed for asthma originally. And it is shown to have benefit in lowering allergic reaction in allergic asthma. Now we're hopeful in food allergy. Does seem to shorten the length of time for patients to reach maintenance therapy and oral immunotherapy, and does appear to allow updosing to proceed more quickly with fewer side effects. That's great. So you get to that first in this escalation day, and then you're trying to updose that patient. Maybe it would take a shorter amount of time, get them to their maintenance therapy, 6 months in the old way, and now maybe in a few months or less. The outcomes need to be studied in more detail. It's not curative, but it is a great option for some patients. So in 2017, 87% of children receiving oral immunotherapy plus Omalizumab, which is Xolair, were able to pass an oral food challenge after 28 weeks of multi-food oral immunotherapy, compared to about a third in the non-treated group. And the Xolair group had fewer adverse reactions. In 2016, there was a phase 2 investigation, recruitment of food allergic patients, compared Palforzia and Dupilumab, and a biologic drug that targets that IL-4 receptor, which can impact the IgE antibody production. This study is more in development, and we're going to learn more about this with this other biologic, Dupilumab. So hopeful that more and more information will become available to you through your providers and through the medical literature. Again, clinical research trials are underway to investigate effectiveness of biologic drugs to treat patients with food allergy, independent of oral immunotherapy, by raising that threshold dose that triggers the reaction. So Omalizumab, or Xolair, is the most widely studied biologic for treatment of food allergy. It can release some mediators in peanut allergy patients at the basic immune level. Dr. Sampson in 2011 showed that up to 80% of patients with peanut allergy, their thresholds increase. That meaning that more peanut was needed to trigger the reaction than before they were treated. David Fleischer in Colorado has shown thresholds for egg, cow milk, baked milk, and wheat increased by not quite 20%, and the rate of food reactions decreased and quality of life improved. This outmatched National Institutes of Allergy and Infectious Disease study. This is a very big study, very well-controlled study done by multiple investigators just to evaluate the effectiveness of Xolair or Omalizumab alongside multiple food OIT. So instead of doing one food like peanut or cow milk, multiple foods like peanut, tree nut, sesame, in addition to Xolair, in hopes that multiple food allergies can be dealt with and lowering their reaction rates, increasing the threshold levels, and doing it not have to go through multiple different OIT trials. So that will be something that we're going to see come out in the future, hopefully in the near future. Use of biologics and food allergy, there can be a faster buildup phase without completely preventing side effects. Reduction or accelerating OIT with cow milk and increased safety, we talked about that, and possibly speeding up the overall execution of the process. So again, going from a long 6-month or so process, going down to hopefully maybe a couple of months or so, which would be a huge benefit for patients and their families undergoing this process. Using Omalizumab as adjunctive therapy for peanut allergy enhances oral desensitization in high-risk patients. Vast majority of patients are able to reach the maximum dose of peanut, 8 grams per day. Fewer reactions during dose escalation, and patients, again, were able to reach higher levels of peanut during the research or the clinical trial. So the bottom line or the message is that more studies are being done. There are going to be more options for you if you or your children have peanut allergy or other allergies. The spectrum is, the options are growing. That's the good news. Dupilumab is this monoclonal antibody that's being used in asthma, it's being used in atopic dermatitis, in nasal polyps, and now food allergy. Been a wonderful addition to our armamentarium of treating atopic disease. 2 big studies are underway to assess effectiveness in food allergy. The aim is to evaluate how much it increases the proportion of allergic subjects treated with OIT for peanut allergy to pass an oral food challenge at 4 to 6 months. The second aim is to assess how many peanut allergic subjects can achieve full tolerance at an oral food challenge at 24 weeks without oral immunotherapy. So this one, pay attention to. This is going to be something we're going to see more and more in the literature and in the press. So a summary of biologics, published data with Omalizumab suggests it is close to entering clinic with indication of patients with food allergy. Use of biologics and food allergy will be clinically useful in the future. Still need more data on the quality of life, adverse side effects of biologics, including anaphylaxis to the biologic itself, but also preventing anaphylaxis. Appropriate dosing will be different than we use in asthma and other conditions. Real-life allergy symptoms, can they reoccur upon discontinuation of Omalizumab? This needs to be studied. Effects may be similar to use of Omalizumab in allergy immunotherapy or allergy shots. This was another place that this was used. So why would your child or your infant or child or teenager be referred to an allergist? If they have suspected or known food allergy, the diagnosis needs to be confirmed so that appropriate elimination and treatment can be instituted. Education on the signs and symptoms we talked about of anaphylaxis, being prepared, having a treatment plan, discuss appropriate elimination diets, and then establish appropriate emergency care plan, not only for schools, for the families when they have maybe babysitters coming in, when there's travel, when there's schools, when other airlines, we talked about that. Recommending appropriate elimination and avoidance diets. I've mentioned that several times. Preventing nutritional deficiencies, deciding on the need for a dietitian nutritionist. I can't stress that enough. And to discuss oral immunotherapy, sublingual immunotherapy, epicutaneous immunotherapy, and biologics. Your primary care providers may not be familiar with this, and they need to be comfortable at what point to refer to an allergist so these things can be discussed. A lot of times the parents are driving this process because they've heard about this either through FAIR or through their other support groups or other parents. So they're kind of driving this process, and the healthcare provider needs to be open to this discussion to then move on to a board certified allergist who can continue the process. Regular follow-up visits, a review of immunotherapy protocol, like where are they in that in terms of their updosing? Do they need to be adjusted based on the cofactors? Updating prescriptions for epinephrine, making sure they're up to date, having sufficient numbers of those. And the allergist can certainly be a resource for the patients, the families, the schools, primary care physicians, making sure emergency care plans are up to date. This is where shared decision-making comes into play. You hear this term a lot now. Physicians, healthcare providers, the patient, the family. It needs to be a combined team effort, listening, having good listening, acting on that listening, and developing the best plan for that patient. So we have time for questions. I hopefully have enough time for a few questions. Marie, we'll take that.
Yeah.
Take that on.
Thank you, Dr. James. I do want to say we had a lot of questions about prevention, and we will not be able to get to those today, but Dr. James is doing a webinar devoted to the idea and the concepts behind prevention on November 15th. So for those of you who have prevention questions, and we don't get to them today, please tune in on the 15th. That information will be forthcoming. So we had several adults with food allergies ask about immunotherapy, what their options are, because a lot of the trials are with children. A lot of we know Plaforza is only for children. What are their options, and is there a different success rate, or why is it not the same? If you could speak to that a little bit.
Great question. And unfortunately, we don't have the same amount of information in terms of success rates, and because the studies have mostly been done in children, adolescents, and younger patients in their teens, but that doesn't mean these can't be done. Your allergists, like I said, I looked at a map recently this summer, and there are allergists all over the country, almost all over the country, doing oral immunotherapy. And some of those allergists are doing oral immunotherapy on adult patients. So you have to investigate this with your allergist. You have to talk to them about what are the options. How comfortable are they doing adults? The protocols can be done. They don't need to be really done any differently. They still have to have an initial escalation day. You have to have updosing done. You have to go through the same process, but you may not have the same benefit, because early on, as the immune system is developing, you like to catch it early and drive the immune system towards desensitization tolerance, because you have that opportunity. Whereas older patients, their immune systems may be ingrained to that, but that doesn't mean you can't ask about it and go through it. That needs to be done if you're interested.
Yeah, great, thank you. A lot of questions around EOE and immunotherapy. One of them was for people with EOE already who are interested in doing immunotherapy for their food allergy. It seems the only option is the patch. Are there other options where things are not taken orally? Are things on the horizon? Or someone asked OIT in conjunction with biologics, decreasing that. So speak to EOE a little bit.
Yes, and we did talk about that earlier in a webinar, and it's so important because this is one of the side effects that has been seen more frequently in OIT. We talked about that. So that doesn't mean you have to go off OIT if it's really working. You can work, a lot of times we'll work with the gastroenterologist and we'll have them do a scope and look at the intestinal tract, see how severe it is, first of all, and then that patient can be monitored. If they're doing well clinically, you don't have to necessarily just take them off. You can do things like you can treat it. There are treatments for EOE. There are things they can swallow into the esophagus. There are proton pump inhibitors, things like Prilosec. So I think the most important thing is to get a gastroenterologist involved on the team. And then you can identify it appropriately, stage it. Is it mild, moderate, severe? And then go forward. Now, the question about biologics is also great because, yes, that might be a way to build them up faster, get the process to work quicker and more effectively. Yes, so that is going to be so important going forward.
And a couple people asked if EOE is triggered by OIT. I feel like I'm talking in acronyms today. Is that permanent or is the EOE temporary? Or does it vary?
It varies, but more likely it's temporary. It's not permanent because there are patients who are on oral immunotherapy. They have significant EOE and they do have to come off of oral immunotherapy because they're not responding to the adjustments or the treatment. But it doesn't mean it's going to be a permanent phenomenon. EOE, once it's successfully treated, even irregardless of OIT, can go away, can improve because the lining of the intestinal tract can repair and can go back to a normal lining. So that's good. Doesn't mean we've made a mistake here. No, this can be treated, it can be followed, but you may not be able to do oral immunotherapy. That is why the patch could be a really, really great option for these patients because it's going through the skin, not through the intestinal tract.
Right. And speaking of skin, a couple people asked if immunotherapy can trigger an eczema flare.
That's a good question. That's not typical. That has not been seen in the studies as a recognizable adverse side effect that's significant. I mean, it obviously could occur if you have really bad eczema, but that is not a significant side effect or adverse event.
And can you expand a little bit on some of the lifestyle changes people may need to be aware of while they're on OIT? We talk about the exercise and showering and doing other things in relation to having the dose. We had a few questions about that.
Great, because this is not only with OIT, this can happen with people that are on allergy shots and other types of immunotherapy. So number one, they need to be aware of those cofactors. Like there's usually, if it's exercise, we usually try to make it a couple of hours before their dose or a couple of hours after. Sometimes patients are riding their bike to clinic. So they're coming from school, they're riding their bike and they're really exerting. So you have to be aware of that and make some adjustments. If they're on non-steroidal medications like Motrin or Aleve, that sometimes can be a cofactor. Viral illnesses, for sure. If they're having an illness like the flu, COVID, other viral illnesses, they need to be aware and tell their provider. May have to hold doses, may need to adjust the dose. If they're going to go on a plane, I'm going on a trip. You take their dose, and I got to get to the airport, and then you don't want to do that because what they have a reaction on the plane, and that can be a problem. With women that are undergoing menses, if that's happening, they need to be aware of that and make adjustments. There was something else I was thinking about. Well, there can be adjustments if they're having an asthma flare-up. We can always make adjustments. We can hold doses, and there's protocols about how to build back up. So the provider, the allergist, needs to have all that built into their protocol. If a parent calls at night and says, "Oh, this occurred," they're having some kind of problem with their asthma, or there are ways to make adjustments because they're usually taking their dose. Well, usually in the morning, you take your dose because if you had a choice, taking the dose in the morning is better because you have the whole day to deal with it than taking it at night and having an overnight problem. So those are some of the things.
Great.
With cofactors.
Great. Thank you. I'm sorry to everyone we did not get questions. The prevention questions, join us on November 15th, or you can email. You'll all get an email tomorrow with information of how to access this, as well as an email if you have additional questions. Feel free to reach out. We thank you for joining us, and be on the lookout again for the November 15th webinar on prevention. And thank you, Dr. James, as always, for your insight and expertise, and we really appreciate it. Thank you, everyone.
Thanks, everyone.